So basically, I believe we were all impressed with the efforts of these diseases and networks that we just heard about. So, and what I wanted to start our discussion, international and between networks discussion, is how we can help in sharing data, sharing approaches, standards, and so on. So, because it makes no sense to do it again and again for each particular disease. And Adeline mentioned that they're planning to use certain things that were developed for ALD Connect, that were developed for ALS and so on. So it makes a lot of sense to work together rather than trying to find sponsorship, again and again. So let's develop our own registry, let's develop our own repository, and so on and so forth, because it takes money, right? So we'd rather spend this money on something else. So if it, again, I'm not sure I need this, but so one of the things, again, to think about is that how to merge all this data, how to merge all this information together. And if you recall my yesterday's talk, we're talking about GUID, Global Unique Identifiers. And I just talked to Jan from Ataxia, and they're introducing this GUID into their patient population. So GUID, Global Unique Identifier, to uniquely identify patients. So basically, if a patient comes to a different institution or comes to a different research project, we can link information across these projects and institutions. And it happens a lot, as you know. So people coming for second opinions, so they move around, or they come here and say, hey, you're collecting information. Yes?
Can you also clarify, is this, for the audience here, the term registry, is that, are you using that term to apply to your GUID?
So the question is whether this global identifier is part of the registry per se. It doesn't matter. So as I just mentioned, for example, part of our ALS effort to deal with medical records and to get information from health records into repository, I would say it's information repository, right, rather than just registry. So EPIC introduced Global Unique Identifier field in all their installations in the world. So any disease, in theory, can use that field to get information if they want to, and not necessarily our Global Unique Identifier. So, but we introduced, so basically to answer your question, Keith, is that we introduced this independent website server called neuroguid.org, neuroguid.org. So any disease with NeuroBank, outside NeuroBank, it does not matter, can use this, safe mechanism to identify their patient population. So that's one thing. So another thing is that we're talking to Elise from France, where they're trying to establish European network or pan-European network, and we're talking to, we're working with GLIA, we're working with ALD Connect, and so on and so forth. So it makes a lot of sense, not to enforce, using the same forms, right? So it's hopeless, right? So people insist using my particular form, and this is it. But at least we need to figure out how to harmonize these data elements. So, and that's extremely important, because you may use, clinicians got used to their own forms and how the way they aggregate data. Investigators do this. So there are certain, forms that were used in one disease, but then they were customized to another disease. But 80% of the fields are the same, for example. So we can figure out how to merge this information from multiple diseases, and maybe there is some sense in it, in this as well. And I'm not even talking about harmonizing data from the same disease or for the same disease. So NeuroBank is, again, I showed you briefly, but basically it's a platform. It's a technology that allows you to enter information in multiple ways. It's flexible. So basically, clinicians can say, I'm looking, so for ALD Connect for the natural history that was mentioned yesterday, so clinicians say, here's the plan for my patient visit, today's patient visit. They click on this visit planning form, what they're planning to collect today, and only these forms out of 30 forms that are part of this follow-up visit or visit encounter, as we call it. So out of these 30 forms, whatever they're collecting will be shown. So it's less intimidating, and it makes clinicians to plan ahead. So with GLIA, Adeline has an incredible idea that is completely different. So from what we have here, which is have this clinicians' workflow where clinicians know what they want, and they got used to collecting this information in a certain way, the way they ask questions, the way they communicate with with the patient, and then out of this information not only being stored in common data elements, but also a note is being created and a letter to the patient with a visit summary and a note that could be uploaded to a medical record. So again, we're trying to figure out what are the incentives for clinicians and researchers to enter this information, right? So one thing that you have a natural history project that is being paid, so you're kind of being paid per patient, right? So Muscular Dystrophy Association, for example, runs its own repository data registry, MDA registry, and they're paying per patient, per visit. It's one model. But if it's not that, so I introduced it, probably patients like me, right? Website where patients log in and they're saying, I have this disease, and they follow. So probably 10 years ago when they just started, and I know these people well because they started as ALS kind of website because their brother had ALS. Haywards. So basically, I introduced this concept, patients like mine. So where clinicians can collect data on their patients, because in medical records, it does not happen. You cannot look across your population. You can just say, this medical record, show me. So again, the idea is how to create incentives for clinicians to enter information and what can they get out of it, right? So in rare diseases, it seems to be a no-brainer, because you don't have enough population to figure out the disease at your hospital. You have to share, but still you have to find this effort. Why do you have to, to fund your coordinator to enter this information? Why do you have to waste your time to enter this information? So I think that that's one of these great things to discuss and still figure out. I don't know how Europeans do this, how other diseases do this. So I wanted to ask Jen about this because, you have a great repository, but how do you make this happen? So that's it about NeuroBank. So Keith, you're next probably before we do the...
We can...
One sec, Florian has something.
So I didn't want to have a discussion sort of fall short that we sort of missed out on before, after hearing all these nice presentations, and Anna's here, and Elise is here, and Sue, and Jen, and Alan, and you've now heard about NeuroBank, and I think maybe let's take a few minutes just to discuss, how to, for instance, the question to Jen, how do you avoid duplication within your system? And what's the value of having something like a global unique identifier? I think what Alex didn't mention is within ALD Connect, we're actually using this not only to avoid duplication across different academic sites, but also to link physician-entered data with patient-entered data and really get the perspective from the patient directly and say, does that match up with what that physician thinks, right? And I think that's important, and Joan and I may not agree on everything, right? So.
I didn't even understand what you just said.
Do you think your son agrees about how he feels compared to what I see and I enter about him, right? I think that's important point, actually, as which is probably something that across diseases, not just leukodystrophies, we should be talking about, right?
I think there were a lot of questions in there, but so the global unique identifier is essential, in my view and my experience. When we started out 11 years ago, this technology was not available, but we did at least have a very simplistic way by name and date of birth and a few key features that, you know, when somebody went to UCLA, there was a way before their data got entered into the database, they got a unique identifier applied to them, and to make sure that this person was not previously seen in Philadelphia. So we had a very simplistic way of doing that to try and keep track of people and make sure we didn't have multiple individuals going to multiple sites with data entered. But we are moving to the global unique identifier. We also migrated over time. Our very first database was a custom-built database. And after about 4 years, in about 2007, 2008, we migrated to an electronic data capture system that is compliant with clinical trial regulatory standards.
Part 11.
Part 11, yes, thank you. I always get the CFR Part 11, yeah. So
CFR 21, Part 11.
thank you. Yep. I just know it's compliant. But it was really helpful because the coordinators and the physicians at our sites now are trained in high quality data collection and data entry. And the forms that they're using for the natural history study are also the same forms and SOPs they're using in clinical trials. So that's been really helpful. But the global unique identifier for us is now a big issue because we have multiple clinical trials, and we want to be able to take the clinical trial data and compare it with our natural history data. And the only way we're going to be able to do that is with the global unique identifier. So it's a must.
No brainer.
So that's great, Jen. And that's for a rare disease where there are probably less patients than ALD patients and AMN patients around the world. So
Absolutely.
I just I want to sort of also emphasize that while while we may be trial ready in treatments and few, but Friedreich is already doing that a lot more successfully. Elise, do you want to speak a little bit about how you use GUIDs, or whether you don't?
I think we're too early right now in our elaboration of the computer part of it and about the low regulation in Europe, where we're still setting it up. So, okay, a little louder if I can. We're still setting it up, so I'll be very interested to see how, before we start, maybe we can implement it. We are, for now, thinking about just the name and the city, birth, and things like that. But if something exists, then I'm definitely interested to hear about it after lunch. Absolutely.
So Anna, how are you keeping track of avoiding duplication when you collect survey information from patients?
Well, I mean, I think there probably is some duplication. Obviously, the Leukodystrophy Care Network isn't at the stage yet where there is a registry set up for all patients. We're still in the beginning stages. So, I mean, Hunter's Hope and the HCA KRI have our worldwide registry for Krabbe patients. So there probably is some duplication of efforts, but I mean, we're very interested in anything available to avoid that, because I think we all can agree, there's a small group of people working really, really hard. So anything we can do to, collaborate in any way, shape, or form, we're completely for.
And just let me emphasize that this became a very practical thing for us because our patients were being seen at different centers, and it was very clear that maybe we didn't have 10 patients in 1 month, but maybe 3 that were seen at different centers, right? So we had to figure that out, and I think that's some of the challenges in the rare disease forum. Asif?
Question for Alex. Do you think your NeuroBank is set up to accommodate or accept from Europe, not the data, but for the GUID, so you can generate GUID without data for them?
I believe I mentioned this. So GUID is not associated with NeuroBank. So you can go and generate GUID from NeuroBank, but there is a separate website, standalone website, neuroguid.org, neuroguid.org. You can go in, self-register as an investigator, clinician. In this case, you will be able to generate multiple GUIDs. Or as a patient, in this case, you can generate just one GUID for yourself, and that's it. So that's why I'm saying that, you may or may not use NeuroBank, you may or may not work with us, but it makes a lot of sense to use this technology. That's
and
it.
that technology will prevent duplication when it's entered in Europe, from Europe or US. What I'm trying to say is that if patient
Correct.
comes to US, go to same website, and this time they will deny it because with this date of birth, name can mess up.
We're
a
not
little bit.
discriminating even Europeans.
No, it's possible because in Europe, middle name can be used as a first name, and they just ignore the first name. Or in other countries, middle name may not be used at all.
Believe it or no, in Europe, and you should know, first names are still in use, right? So, but I don't disagree with you. I don't disagree with you. There may be some countries, not necessarily European, but there may be some countries that differ. So, that's why we have an option, for example, not to use middle name, because some European countries don't use middle names, and so on. So there are some options. The original GUID technology also contained social security number. So we removed that, right? So because, first of all, it makes no sense in many European countries, and people will be reluctant to use this if they have to enter into American site some kind of identifier. So, I believe I mentioned this before. So the same GUID should be used, so for LS it's being used for identifying whole genome sequencing files that are being sequenced at New York Genome Center, for example, and you can do this. So the same GUIDs are on labels. If you recall, I was showing this yesterday on the vial labels and so on. So on the tissues, post-mortem tissues as well. And then right now we're working on ALS, at least, to see whether we can create a generic anonymization program for images that will substitute patient IDs and patient names and so on, like hospital imaging systems have with GUID and the visit time point number. That's it. So I can easily predict that in several years or even sooner. So someone may be calling and saying, "Hey, I have this GUID GWAS file, so BAM file. Do you happen to have images, or do you have a CSF for this GUID?"
One more, Alex. So in the end of the studies, or listen, the ELA also have this database using the GUID. The patient's information is there, and one investigator want to combine those two data sets. One gets it from ELA and gets it from you. Do you think these two data sets can be combined, merged some way? Is there a technical process?
It's not a technical process. It's not a technical challenge. Certainly, two data sets could be combined, right? And I described this PROACT database that we created out of clinical trials in ALS. The challenge is whether they're allowed to be combined. So whether consent forms were initially structured the way that this data could be combined and put together, that's one thing. Another thing is whether investigators who are the holders of this data set are willing to combine their data sets. So we put in all our NeuroBank consents that the data, anonymized data, will be swept and combined. So that's the ultimate goal, and I believe it should be. There's no reason not to do it in other diseases, right, Jim?
So, Alex, behind you. Sorry, you're other behind. So a couple of things come up here that I think a couple of things come up here. One is, and so a couple of questions. One, is this part of an NIH standard or something that's being driven at a very high level? I mean, I understand the technology in it, and you're very enthusiastic, but how does this get broader? The second is an observation in terms of historical data. Should we be going back to existing registries and data sets and GUIDizing them?
Great questions.
And then the third is just kind of a general comment, which is there's all kinds of problems with consent or merging databases or whatever. That really, those issues are separate from creating a unique identity for each patient. And we need to separate those conversations and say, wait, if we can just get a unique identity for a patient, then we can start working on those other problems. So there's a step.
I will start from the third comment. So basically, our IRBs, at least for academic institutions, demand, require that patients consent for a global identifier to be created for them.
But you have to create an identifier for a record anyhow. Why can't that be the default?
There is one difference. The difference is that one thing, you're creating an identifier for your own registry, right? But this good, eventually, and that's the goal of the objective to create this good, it will allow to link the same patient information across multiple data sets or multiple projects, right? So basically, you have to tell the patient that, hey, your data will be, not knowing, I mean, people will not know who you are, but they will know that the same person participated in this project and in that project. So that's the reason for IRBs and ethics boards to be aware of this. So retrospective, it's quite fascinating. So let me start with the first then. So the technology, as I mentioned yesterday, was created by the NIH for autism research database. And NIH, Patricia is still here somewhere? So NIH was basically, they asked all investigators who were getting any federal grants to submit all their data on their patients back to them, and this GUID was meant to link this data. So, but because global medical record, that's what GUID is, right? So it doesn't make any sense in politically correct way. So they decided that it makes sense for a disease-specific medical record. So that's why for autism research, they had identified that says this is for autism research. So when I approached the NIH and asked them why not to create ALS prefix for the GUID, so they told me no, because it's based on the server and they have a single server and they're not willing to do anything. So but then I suggested why not to give me the technology and I will manage our own server for this and I will substitute AUT for ALS, and half a year later they agreed. So they gave us the technology. I believe it's quite unique that the NIH had a technology transfer agreement with the Mass General Hospital. So they gave us the technology, we changed this, we removed that social security number and so on and so forth, and we have this. And when I reviewed the contract agreement between the NIH and MGH, it does not specify for which disease we can use this. So that's why instead of saying ALS for the prefix, I put NEU for neurology. And no one objected, kind of. So 3 years later, now the NIH has 5 or 6 GUID servers per disease, including traumatic brain injury, the latest one. And now the question is how to merchant all this information. So especially if we're talking about some comorbidities, right? So multiple diseases for the same person, and it makes kind of, currently the statement is no way, because that's the reason, right? So if this person has this disease, so investigate it separately from that disease. So coming back to your second question, so GUID allows you, the technology, the server and the technology itself, allows you to create so-called pseudo-GUIDs. So pseudo-GUID is if you don't have enough information currently for your patient, you can say, okay, so this is the first name, last name, and I have no clue where this patient was born, create me a pseudo-GUID. So eventually when you have this information, you can turn this pseudo-GUID into GUID. So that's one thing, but this is kind of for prospective studies where you know that eventually we'll know these things. So for retrospective studies, for example, in ALS we have a project, so we have a network for postmortem tissues. So obviously you cannot get information, unfortunately, on these people where they were born, right? Not necessarily known. So in this case, because we know that no other information will be eventually aggregated on these people, so we created this, and the only thing that is not known is where they were born, the municipality and country of birth. Everything else is in medical records. So we decided that for that particular project, for post-mortem tissue repository or biorepository, so we have date of birth and country of birth fixed to the sponsor's name. So it was Target ALS. So we have Target ALS as the town and USA as the country. So in this case, you can do this. But the problem again, and this is what we're fighting with KKI registry and so on, is that we have historical data where patients have not consented to this. And the IRBs, unfortunately, are not allowing us to do this. I mean, maybe they will, right? But we're still fighting this particular one. And if we can figure this out, that would be unbelievable, because we have so many data, rich data sets, that we cannot merge because of that. And we would not know, right? So whether, so one of the things I introduced as a concept several years ago is to create this Uber consent that would allow patients to say whatever was collected on me, you know, in my previous lives and previous, so I allow this to be used. So, I mean, if we're changing our wheels, right, at will, so why not to do this for our consent? So I'm not sure whether it's legally doable, but I think that's another way for foundations to pick up this fight. I think it's well worth it.
Yeah, thank you. And again, when you say merge databases, kind of the hair on the back of my neck goes up, because it's not always merging databases, just knowing where the data is, and in those specific cases where you can get consent, hopefully that percentage grows, then you can pull that data together. It doesn't necessarily, a lot of people think in their institution, oh, all of my data is now going to go to MassGen, and that's not the case.
No, I'm not, and MassGen does not own data.
No, I keep saying this. Right? You say merge, but I say link. And I think we need to be very careful about not assuming we're trying to pull things together. We're trying to connect
And
them.
I believe I said that in the first place. So ideally, we would need to figure out how to harmonize, right? So, and link. So inventory is one thing. Linking is the next step, right? And merging is the third one. So.
Thanks, Alex. So again, I think many shared challenges, and the approaches is what we want to talk about. And so I think